So thank you and welcome to everybody. My name is Bill Patjane. I'm the Executive Director for the American Parkinson's Disease Association, Massachusetts chapter, and welcome to today's presentation. The APDA of Massachusetts has been in operation for decades and offers programs and services to the PD community in Massachusetts and surrounding states. We received a large response for this presentation, and we want to thank you for being here today. There has been a tremendous amount of progress in understanding and treating Parkinson's disease. Parkinson's disease is highly individualized from person to person. Not all that is discussed today is relevant to everyone. The healthcare team must be familiar with the signs and symptoms, treatment strategies, and how PD impacts the individual patients. Treating PD requires a team approach, and today we are providing information that is not intended as medical advice. So here in Massachusetts, we operate a few key components to services in the area. One is the Information or Referral Center, and that's at the Boston University Medical Campus. The phone number is 617-638-8466. There we actually do referrals and we provide resources to the community. We additionally provide information on education and support, including support groups, symposiums, and educational events. Here in Massachusetts, we also provide health and wellness services, exercise and movement classes. We have a fitness professional training program. And at BU, at Sargent College, we also have our APDA National Rehabilitation Resource Center. Thank you. This gives an overview of how we interact with the national office that is based on Staten Island in New York. We have the national office that, is the umbrella organization. Massachusetts has a local chapter. We operate the Information and Referral Center at Boston Medical, the Medical Center. We have support groups. We have National Resource Center for Rehabilitation at Sargent College at Boston University. At Boston University School of Medicine, we have Advanced Center of Research, and we have another Advanced Center of Research at Brigham and Women's. And so without further ado, what I'd like to do is introduce our speaker for today's topic. I would like to introduce Lisa Sommers. She's a speech language pathologist, SLP, in clinical practice and in the communication disorders department at the University of Massachusetts, Amherst, as a clinical associate professor and as a clinical director in the on-campus speech and hearing clinic. Lisa works with graduate SLP students to teach and model that is vitally important to get for them to get to know the whole person, not just the specific disorder. Lisa also takes students to the APDA support groups and runs a PD communication and swallowing wellness group at UMass Amherst. Lisa is also a board advisor to the APDA Mass chapter and has been incredibly valuable and important to the organization. We're really excited about having Lisa today. Lisa's topic is critically important to the PD community. And today, participants will learn the latest on Parkinson's disease and communication. As we move forward through Lisa's presentation, if you have questions, please put those questions in the chat box or in the Q&A box. And at the very end, we'll have Lisa answer those questions as we finish up the presentation. And so I'd like to transition over to Lisa. Thank you, Lisa.
Thank you so much, Bill. Yes, as Bill said, I'm at University of Massachusetts Amherst, and I've been a speech language pathologist for over 30 years now. And prior to coming to UMass in 2014, I was in clinical practice, and one of my specialty areas was Parkinson's disease and working with people with Parkinson's disease. It's been really exciting to bring that clinical knowledge and take it into a student training setting and really pass on the things that you can't really learn in a textbook. And one of the things that I have developed is some types. I've been lucky enough to be in a setting where I can create some programming for people with Parkinson's disease that is beyond what they get in individualized therapy, but sets them up to be very successful for accessing therapy and understanding the importance of paying attention to these areas in communication. So what I'm going to talk about today is one aspect of what I do as a speech language pathologist and what you could expect that a speech language pathologist that you interact with would be doing with you. And that's working on people's changes in communication associated with Parkinson's disease. But there are some other areas that I'm not going to be talking about today that are equally as important, swallowing being one of them. And so I just want to underscore that that's a whole nother area and a whole nother talk. So today I'm only going to be talking about communication changes in Parkinson's disease, but there are some other ways that you might be interacting with speech language pathologists if you have Parkinson's disease. So we know that about 90% of people who are diagnosed with PD will experience changes in their communication. That's a really high percentage, but I can personally attest that just experientially, that has been my experience as I've sort of walked this journey with people that have PD. And the changes can be really subtle, and just like other things with PD where you look back, before you were formally diagnosed and you say, gosh, I think I was having those issues a while ago. And that is often the case with changes in speech, voice, cognition, and swallowing. And so the areas that can be affected in terms of motor speech and sort of the speech and the voice aspects of communication are things like breath support. Voice production often changes, so the voice becomes softer. That's a hallmark kind of thing. Sometimes hoarse sounding, the quality of the voice can become hoarse, breathy, or harsh. Speed and accuracy of articulation can change as well, so there can be reduced clarity of speech. People describe their speech as starting to sound kind of mushy. Um, Inflection of the voice is also impacted. In inflection of the voice and then the reduced facial expression that sometimes goes along with PD, um, can both those things can contribute to people appearing to be either depressed or disinterested when they're actually not at all. And so those are aspects of communication that people don't necessarily think about because they're a little bit more within the realm of nonverbal communication. However, we know nonverbal communication is incredibly important to our effectiveness as communicators, and that people process a lot of that information without even realizing it. And so it can really contribute to giving an impression of someone being engaged or not engaged as your communication partner. And so it's vitally important to address those things as well. On top of all of these sort of motor aspects that can change, there's this other really interesting phenomenon with PD, and that there is sort of a sensory disconnect. So a lot of times people are not really feeling as if they're communicating any differently than they ever did. It feels the same to produce speech, to use their voice as it always did. So a lot of times they're really not convinced that they have an issue with their voice or their speech. They're often telling me that I'm not the one that's too soft. I'm sure that my spouse needs a hearing aid or my care partner needs a hearing aid. That could be true, but we also know that one very classic feature is this soft voice, and it really does contribute to a lot of communication difficulties. When I play a recording of someone um, who doesn't think that their voice is too soft and they hear themselves, a lot of times they can perceive that indeed their voice is much softer than they realized that it was. But it's sort of this internal disconnection with how it feels to produce the voice versus how it's actually sounding. Unfortunately, medications have not been shown to be effective with speech, voice, and swallowing changes. Medications can sometimes be very effective for people's gait and things like that. But in terms of these motor speech aspects and swallowing, not so much. So we really need to be looking at um, symptom management. We need to be looking at exercise-based approaches to working with people with PD, and these can be very, very effective. So we're going to be talking about that today and some of the treatment techniques that have some pretty good evidence, actually some great evidence associated with them. And we'll talk a little bit more about, the underlying reasons for that. In addition to these motor speech changes that people experience, people can also experience some cognitive changes. And I want to emphasize again here, just as with everything else that we know about with PD, and I'm sure you've heard this over and over again, and I'm just going to be reinforcing this same message because it's true, that, it is not a one size fits all kind of thing. And some people experience very few changes in their cognition, and some people experience quite significant changes in their cognition. I'm bringing it up though because it's something, number one, that I find a lot of people carry around a lot of fear about. There's a lot of, it's a delicate conversation to have with people, but changes in cognition really impact your ability to communicate. And we're going to talk a little bit about what underlies all of this. And, it is again, some days are better than other days. It can be variable. And of course, it's variable between people as well. But some typical kinds of things that, I've given you some examples of what these different cognitive domains really kind of are like. Things like attention and concentration. It can become harder to pay attention. It can be harder to hold your attention on something. And it can play out in a lot of different ways and can be things like being able to read a recipe while you're prepping a meal, talking on the phone while shopping, dividing your attention between something, or selectively attending to something like having a conversation at a party while you're ignoring other conversations behind you. People with PD have reported to me that they're noticing more difficulty with those types of things. Memory is something that people, obviously hold a lot of worry about because they worry about their memory. We all worry about things like this as we're getting older too. And so sort of trying to piece that all out, there's still a lot of research that's going on around cognition, but it doesn't appear that people with Parkinson's disease in general have as many sorts of memory changes as, for instance, someone with Alzheimer's disease. But certainly some things that people will report is that they're particularly having difficulty learning a new skill or new information, or learning a new way to do something that they've done a certain way, sort of a procedural memory task. So then having to kind of unlearn that and replace that with a new way of doing something and remembering how to do that. Sometimes that can be difficult for people. And executive functions are higher level cognitive tasks that kind of take everything that we have in terms of our cognitive resources, because it's usually those complex tasks like managing our finances, managing medical appointments, medication management, higher level decision making, managing our emotions in complex ways. These are all things that involve executive functions. And sometimes people with PD will notice some difficulties in these areas as well. Additionally, some cognitive changes that involve language or difficulty thinking of words quickly, especially. So, we all experience some changes in, can't think of people's names anymore and things like that. But people with PD will report that, especially when things are happening in a complex way in terms of language, it can, like conversation, or when they're dual tasking, they're doing, going for a walk and having a complex conversation with a friend. That's when they might experience more difficulty thinking of the words that they want to express themselves. And then, of course, this is also interrelated. So if you have motor difficulties, you have to think about being louder when you're speaking, or you have to think about trying to write with more regular size writing as you're trying to think of the words that you want to use to express yourself. Sometimes those two things get interrelated and complicate the issue. And then a lot of people with PD talk about that they experience sort of this more slowness of thinking, but also just slowness of processing what people are saying to them, separate from having a hearing loss per se, but more like it's just I process things slower. So it takes me longer to process what someone said and then longer to respond back, because then I have to think of the words that I want to express myself. Another area of cognition that sometimes changes with PD is visual spatial difficulties. I notice this when I work with people in like a choir setting, and we're singing, and for people that even knew how to read, were musicians and knew how to read music and lyrics, being able to simultaneously do that and keep your place when you're reading, even line to line, sometimes can be difficult. So people report these sorts of challenges as well. We're going to be putting a link in the chat to a webinar that's happening, I believe, tomorrow. Dr. Gilbert is hosting a webinar tomorrow specifically on cognition. So if you have more questions about this and you want to learn more about it and more about the research that's associated with changes in cognition with Parkinson's disease, we'll put that link in the chat for you. I think that will be helpful if you're interested in that. So other things that impact communication that people don't often think about and that are potentially treatable in a way that can positively impact cognition are things like depression, anxiety, apathy, issues related to medications and sleep disturbances, and hearing loss. So all of these things have some treatments that are sometimes available, and these are all areas that can really impact your cognition. And we really want to think about understanding those, recognizing that those are present, understanding those, and doing something about some of those, because those are potentially some things that could reverse some of the things that impact your cognitive changes that you might be noticing. It might not take away all of the cognitive changes that you're noticing, but those are some things that sometimes treating some of these areas can positively impact your cognitive functioning. So we're going to talk about this last one, which is hearing loss. And this is an area that I don't hear a lot of presenters talk about, and I don't hear a lot of people coming to me in my clinic really talking about anybody asking them if they're having any difficulty hearing. However, a lot of people, not everyone with PD is older, but a lot of people with PD are older. Well, when we think about the statistics of this, worldwide, 1 out of 3 adults age 65 plus have hearing loss, and this increases to 2 out of 3 by the age of 70 or over. So among those people 70 and older with an aidable hearing loss, meaning a hearing aid might be helpful to them and might really benefit them, only around 30% of people actually do have hearing aids. So you can see there's such a big public health issue around hearing loss. And we know there are lots and lots of barriers with people getting hearing aids, cost not being the least of them. And Yet, this is something that we don't really think about being an aspect of communication that can really benefit people with PD, on top of the fact that there also appears to be a link between cognitive decline and hearing loss. So, recent studies have shown that hearing loss is linked to cognitive decline, and we don't know the exact nature of that link yet. So there's a lot of researchers that are studying this, and some of the researchers in the audiology department at UMass that I work with are studying this very thing, trying to really start to piece out this relationship between hearing loss and cognition. We know that hearing loss can lead to sensory deprivation. We know that it can lead to social isolation and depression when it goes untreated. And we also know that a hearing loss puts an extra cognitive load on people. It's a cognitive effort to go through the world, not being able to hear what's going on around you. That alone can really be a huge load for people. So I really want to bring this up because it's so important to the people that I work with, and it's often not discussed. So I've talked about all of these changes that can happen in PD, but I really want to talk about the personal impact that this has on people because that's really what this is all about. Um, Obviously, when someone is experiencing communication changes, when they have to repeat themselves over and over again, when people start ignoring them or interrupting, or not even realizing that they're talking and talk on top of them because they can't hear them, this can lead to a great deal of frustration. And then it leads often, and I hear these stories over and over again, it often leads to changes in routines due to a decreased ability to participate in these activities. So people start having their spouse order for them when they go to restaurants. Um, and people will, instead of going through the drive-through, they need to go into the coffee shop because people can't understand them through the drive-through anymore. They stop answering the telephone or talking on the phone with people. They stop going to dinner parties and social gatherings. It's very aggravating and exhausting to repeat yourself. Sometimes people are misunderstood because their facial expression is decreasing and their voice is very monotone, and so they might say something that's humorous or sarcastic and they're misunderstood because they don't have the right affect going along with the words that they're saying. So there's a lot of stories of people being misunderstood, particularly for people that are still working, will often report that their voice is starting to get in the way of them doing their job. Their communication problems that they're having sometimes are really impacting their performance or someone's perception of their performance. And so, really working a lot with people that are just experiencing subtle problems. I cannot say enough how early treatment can really, really benefit people. And I found over the years that people were coming to me so much later than they should. They were coming to me once they were having pretty significant difficulty being understood by others. And, looking back, they could recount stories of, they just thought that this is what they had to deal with, that this is just what Parkinson's makes happen, and they didn't know that there were any treatments that were available. And so I really am very passionate about making sure that people understand how important really thinking about this, being aware of very subtle changes is so very, very important to the quality of someone's life and even, career issues with people. So people often will curtail their normal activities like volunteering or doing things socially. Obviously, um, beyond the risks for depression and apathy that comes with Parkinson's disease is the depression that comes with feeling isolated and not being able to express yourself, an impact on your self-image. And a lot of times these things happen so gradually that people are not even aware that they're starting to just be very quiet at a dinner party and no longer really speaking up. And they just sit and listen and let their spouse do the talking. And that can happen so gradually that you don't even notice that it's happening. So let's talk about some treatments then, because there are some very, very effective treatments. But before I talk about those, I really want to have you think about what really makes for the best outcome when you decide that you're going to enter into a relationship with a speech language pathologist, and what do you need to be looking for, and what do you need to be thinking about? What makes for a really good outcome from therapy services? So you hear people talk all the time, and at the APDA, it is very much a focus of making sure that we are thinking about the science behind the treatments that we talk about, and that we educate people about in the Parkinson's community. And research is incredibly important. But, research and evidence is not just the scientific literature that's out there, which would be external evidence for what we're doing and why we're picking a certain treatment technique with a patient, but also from data and observations collected on each individual person that we work with, our internal evidence about what's going on with that person. And that really helps to inform the decisions that we make. And of course, you want to have a clinician, a speech language pathologist that is an expert, has expertise in the areas of Parkinson's disease. They have knowledge and judgment and critical reasoning skills that they get through their training and through their professional experience. That's incredibly important. But it's not just about that. You are the other part of this, dynamic intersecting um, relationship amongst things that makes for best outcomes. So you bring a unique set of personal and cultural circumstances, your values, your priorities, your expectations for the treatment, what the situations are in your life that you want to work on. And it's really the coming together of all of those things that makes really best outcomes in therapy services. So I want to talk a little bit now about some evidence-based treatments that I'm familiar with. This is certainly not an exhaustive list. However, these are some gold standard treatments that have a great deal of research associated with them and many, many years of many clinicians practicing with these techniques. LSVT Loud stands for Lee Silverman Voice Treatment. And this treatment technique is a treatment technique that is specifically for Parkinson's disease. They are studying it now in other populations as well, but it was originally designed to work with someone who had Parkinson's disease, and they had such good outcomes that they really started trying to figure out what is um, what is the most important things that we focus on in this treatment technique. And the most important domain that we really focus on in this treatment technique is the voice. By focusing on the voice and one thing only, we have a set of exercises. So it is a protocol of sorts in that it's a certain set of exercises that we have, but then it's also individualized for the patient. So the first part of the therapy session is always a set of voice exercises that we do that are the same every time. But then in addition, we then customize the rest of the activities around what's functional for you. What do you need to be able to do better when you're functionally communicating on an everyday basis? It's intense. So this is one of the therapy techniques, one of the few therapy techniques that has really been studied in terms of dosage. So we understand after the years of doing research on this that the intensity of this research or of this treatment approach really matters. So 4 times per week for 4 weeks, for the most part, is usually how long it takes. That sounds pretty overwhelming to people because 4 times a week sounds like a lot, and it is a lot, but that dosage yields really great treatment outcomes. and they've studied different dosages and haven't gotten the same outcomes, studied focusing on articulation rather than voice. They've studied looking at breathing rather than voice. And voice at 4 times a week for 4 weeks is the most effective, gets the best outcomes. Sometimes it takes longer than 4 weeks for some patients. And obviously, again, I can't emphasize enough that it sounds as if it's a one size fits all treatment, and it is not. And it really is the gold standard. The other part of it that is really wonderful about it is while we focus on the voice, we see improvements in articulation. We see improvements in the way people breathe. We see improvements in facial expression. When we see improvements in the inflection in their voices. And then we also see improvements in swallowing. So it really does have many, many years of great research. It takes a specialty certification, so the therapist has to be trained in it. I've given you the link there to their website. And on that website, you can go and you can locate a clinician, a certified clinician that's close to you. Additionally, LSVT Loud can be delivered via telepractice. And we have been doing that in our speech and hearing clinic on campus. And they have also studied it in telepractice and are getting outcomes that are the same as the outcomes that they're getting for in-person services. So that's really a game changer for people with PD who often have a really difficult time getting out of the house 4 times a week for a month. And so this has been something that the pandemic has, you know, I think opened a lot of, I'm excited about the fact that insurances and Medicare is covering telepractice services. And I'm hoping that that continues after the pandemic is over as well. LSVT Loud is covered by insurance. It's the same coding and billing as, any other kind of speech language pathology services. The Speech Vibe is a device that's worn in the ear. So this is an external device, so it looks a little bit like a hearing aid, and it's inserted to the ear and kind of goes back over the top of the ear. And I've given you the link there, and you can go and look at a wealth of information on these websites. It's based on the principle called the Lombard effect. And the Lombard effect is the reflex that we have that when we're in a noisy environment, we just automatically raise the volume of our voice when we're speaking. So the Speech Vibe device introduces background noise into the ear. It's not to the level that it would hurt anyone's hearing, but it is to the level where it triggers this Lombard effect. And then people will automatically increase the volume of their voice. A trained speech language pathologist needs to set up the device and calibrate the device. It's not as an intense therapy schedule as LSVT, but it does require the person to put the effort into their voice in a similar way. So it's based on the same sort of foundation. And we know that people with Parkinson's disease are very, very capable of increasing their volume. And that's really what we're driving the muscles to do with both of these therapy techniques. The other things that I've listed here are complementary sorts of things that we sometimes will add in if we need to. Amplifying the voice, particularly for people that are at more severe stages of impairment, incorporating pacing boards to help people regulate their rate, and then augmentative communication for someone who's so severely impaired that they can't communicate verbally. So just to get you thinking about being a consumer of speech language pathology services, because I think it's really important to think about what's important to you. What do you need? What do you anticipate needing when you work with a therapist, and what can you plan for and be ready for as you go to engage in these services? And so understanding that it is intensive and the intensity of it is really, really important. just like with physical exercise that you do, intensity is very important for the physical exercise that you do to manage your symptoms. And it is the same way to manage your speech and voice symptoms as well. The the thing that I feel so fortunate being a speech language pathologist is that it's really a relationship based kind of therapy, and it's very highly individualized, and it's just really important to have a good relationship with the therapist. You spend a lot of time together, and getting to know each patient that I've had has been such an incredible privilege and tremendous learning experience for me, just even personally. Therapy is exclusively focused on the voice, particularly, when you're doing all of these focus on, motor speech problems. Ideally, the speech language pathologist should have advanced training and certifications, as I talked about, but they really need to be able to bring it back down to the everyday and focus on what kinds of communication situations are important to you as an individual. Obviously, they're evidence-based, and we're thinking about all of those three bubbles coming together when we say evidence-based, and they're beneficial to all severity levels. So I want to talk a little bit about this because I think that a lot of people, especially people that are very, very mild or very early on in the diagnosis process, and they might say, "Oh, no, that's not really me. I'm not really experiencing any difficulty." I really want people to change their thinking about that. I really want them to be reporting even subtle changes to their doctors and to be thinking about any subtle changes that they're experiencing. Even if you don't think that you are having any difficulty, it's great to get a baseline evaluation, just like you would in physical therapy. I think that that's become more of a standard of practice, and that neurologists are much more often saying, go ahead and get a physical therapy evaluation, and they're going to set up an exercise program for you or talk to you about how to exercise and educate you about that. We want to be doing the same things in terms of people's communication skills. And speech language pathologists basically should be, you should think about them as being with you across the continuum of a variety of different types of services, and across the many years that you might be living with Parkinson's disease. So doing evaluations and treatments and re-evaluations, collaborating with other medical professionals, and looking at speech and voice and language and cognition and swallowing. And those are, a lot of things on that list. And there are a lot of things there's such a complex thing. Our brains are so complex, and communication and swallowing is so complex that it's a really good idea to develop a relationship and develop your team, as Bill was saying at the beginning. And that team really does need to also include speech language pathologists very early on in the disease process. And the good thing is that, virtual sessions are very, very effective with speech language pathology. But I just need to put a plug in here, and no pun intended, that you really want to make sure that if you're working with someone and you're focusing on your speech and your voice, it requires a good Wi-Fi signal, a camera that needs to be on. You wouldn't want to be working with someone that didn't want to lay eyes on you, and that's really important. The microphone, of course, has to be working, and because it's sometimes some challenging technology, having someone to help you with the technology on your end can sometimes make a really big difference and help people not be so frustrated. So I want to talk a little bit here about a group that I developed at UMass. And part of the reason that I developed this group, that is really an education group, is because when I was in clinical practice and I would have people with Parkinson's disease come to me, I always felt like they were coming to me too late. I felt like there was so much I could have done if I could have worked with them much earlier on, when they were newly diagnosed, or when they were so much more mild in terms of the symptoms that they were showing. And, it just felt like there was such a huge education piece that if I could only have the time to teach people a little bit more about everything that goes into communication and swallowing, then when they would actually maybe start to have some symptoms, they'd catch them early. we'd be able to nip it in the bud, we'd be able to address it quickly, and they would know what they were getting into when they were being consumers of speech language pathology services. So when I started at UMass, I realized that I had this wonderful and unique opportunity to have students that could help me with this. And then the other part of this that is such a win-win situation is that then the students learn from people with Parkinson's disease and their care partners and develop relationships. So I've developed this group that is an education group. It's been supported by the APDA. I think my first group was in 2015. And we've been doing it virtually since the pandemic started. And that's been really exciting because I've been able to, work with a lot more people across Massachusetts that I wouldn't have been able to work with if we were in person. But we basically do a lot of education around just the things that I'm talking to you about today, in addition to nonverbal communication, swallowing, hearing, and we have expert guests come in and talk. We really focus on self-advocacy. And then as new research comes out, I'm updating the group, and I'm also always taking in feedback from the participants and their families and modifying the group as we go along. So it's been a really, really wonderful opportunity to be able to do this. I'm not going to say a lot about singing, just want to make sure that I note that I want people to be remembering that singing is not speech language pathology services. We have some small scale studies around singing, and they have some promising results, but it took all those years of LSVT research for us to figure out the dosage and to figure out what parts were really, really important. We are not there yet for singing, and singing should not be used as a substitute for speech language pathology services, but as a complement to it. That being said, I'm a singer, and we have a singing group. We have a choir. It's really successful because we have a collaboration of a variety of professionals that are coming together for that group. And so it really has benefited people's mood and keeping them socially connected, and particularly as a great way to kind of maintain your skills after individualized therapy. So just a little note about if you are experiencing cognitive and language challenges. That is another thing that speech language pathologists will sometimes work with you on some cognitive language issues that you might be having. Often it usually starts with the person talking to their physician about the problems that they're experiencing, and a neuropsychological assessment is often recommended. But if there are treatment strategies that would be effective for the person, usually it's a speech language pathologist that's going to be doing that with you, not 4 times a week, usually very focused and solutions focused and shorter term. And then in terms of treating hearing loss, I work with audiologists, and so I've given you a couple of links here for how to find audiologists. Obviously, we know that some people do not want or cannot afford hearing aids, and then there are other things that can be considered: assistive listening devices, personal sound amplification products called PSAPs are becoming more and more common. But bottom line, and the only point that I really, I'm not an audiologist, and I'm not an expert in audiology, but what the point that I really want to get across to you today is, please do not ignore hearing loss, because we know that it has far-reaching implications for people, and denying or dismissing it is really not going to be a way to help your communication skills at all, and it really can be a link to a lot of worse problems. So we really want people to face it and work on it. Just a little bit about just the basics of communication. We're all wearing masks now too, so that just adds another layer of complication. And so if you are communicating with someone, you're a communication partner to someone who is having expressive difficulties, make sure that you're giving them your undivided attention. Use the context that they're talking to you. What might they be talking about based on context to sort of help be predictive in what you're hearing? tell the person what you did understand so that they don't have to repeat the whole message and they only have to repeat the part that you didn't get. Wait. People with PD a lot of times take longer to formulate their thoughts, longer to search for the words that they want, and then longer to produce the speech. Don't interrupt. And then think about, if I'm wanting to discuss something with someone and it's an important discussion and I want them to be at their best, try to work around their off periods that people are having. If someone's contending with a lot of dyskinesias coming up, it's going to be really, really hard. That's a cognitive load right there. So it's going to be even harder to communicate in those times. This one is one that you wouldn't think I would have to say, but we're all guilty of doing this, even though we know we shouldn't, communicating over long distances. So just getting closer to the person, making sure that there's not background noise, the TV is off, they can see you, and you can see them. Help people out by using yes/no questions. Restate what you heard and ask and clarify that, and then be honest with them. Don't fake that you understood something that you didn't actually understand. Be honest and just work through the issues. Um, and just a little note, these last two are a little bit more about the facial expression and the inflection in the voice. But a lot of times, one of the things that we work on with people in our group is to really help them understand that for your listener, if they can't read your face and your intonation is pretty flat, it's really important to be able to talk about your feelings. I don't know how many times, even I as a professional, knowing what I know, I look at someone talking to me, I think they don't like me. I don't think they like me, or I don't think they believe what I'm saying. And then I'll say to them, "How do you feel about this therapy? What's your thoughts about this?" And then they'll say to me, "I'm so excited. I can't believe what an opportunity this is. I can't wait to get started. Your students are so wonderful." I wouldn't know that. My Another part of my brain that processes nonverbal communication is just being tricked, and it's just thinking that they are not engaged at all when they actually are. So asking someone to verbalize their feelings is a really great way to really find out and to circumvent that problem that we have with the nonverbals. And then the more expressive we are as a communication partner, the more we can draw that person with PD out to be more expressive as well. I have a link here from LSVT where they have a little suggestion sheet for communicating with masks on. And then in terms of assisting someone who is having trouble comprehending or hearing, slowing your rate of speech, but don't go too slow. Make sure that they don't feel talked down to. Pausing strategically allows people a little extra time to process what you're saying. And just doing those kinds of strategic pauses sometimes can really help. Increasing your volume, but not yelling. Facing the person, being in good light, shorten things, keep things less complex, provide details in writing, use nonverbals. We've written a booklet for the APDA, myself and two other colleagues. And if you're interested, you can download this publication. So I've given you the links here. And here are some references for you. And I think we're ready to take some questions if people have them.
Sure, Lisa. Thank you very much for your presentation. That was incredibly informative information. So one question I have is, I have rapid speech and it's hard to slow down. Do you have any recommendations for that situation?
Yes, yes. So the first thing that I would try with someone who has really rapid speech is LSVT would be the first thing, because a lot of times just focusing on the voice and increasing the volume actually can impact people's rate of speech. Now, sometimes when we're doing that, we find that people still have some difficulty with their rate. It can take us part of the way, but it doesn't get us as far as we want. That's usually when we would bring in something like a pacing board. And, sometimes people don't need to use their pacing board all the time. They can, just get some of the improvements from LSVT just by the increased volume, and that will improve their rate. But sometimes they need to they have some situations, particularly if they're nervous or if they're on the phone or if they've got a big cognitive load, they can use their pacing board to slow themselves down as well. So sometimes it's kind of combining some different techniques, but it's definitely something that you would want to seek out the services of a speech language pathologist to help you with that, because that's what we're trained to do.
Sure. Another question is, a person had a wife who was involved in a choir and had a fall, and over the course of the last year hasn't been able to participate in a choir. Are there any other recommendations other than getting involved in a virtual type of choral group? Anything that you would recommend as far as therapy?
Well, again, these are the kinds of things where I guess it would um, depend on what else is going on with the person's communication skills. So just like I said in my slide about singing, singing is not a substitute for skilled speech language pathology services. And if you're having difficulty with communication, I would always think about the choir as the complement to the skilled services. And so if you're experiencing difficulty with communication, I would definitely explore the possibility of, like telehealth services, so speech language pathology services virtually. Medicare is covering that right now, and a lot of other insurances are as well during the pandemic. And we've just had a lot of really great success with people. Particularly for people in the Parkinson's community, it's been a real game changer for some people accessing services.
Great, thank you. And I just want to remind everybody that if you have a question, we're going to continue to take questions. Please put those questions in the chat box. Another question, Lisa, is person had vocal cord surgery and was quite successful. His voice improved significantly. Person actually had participated in your program previously. Articulation has now become a bigger problem.
Mhm.
Is there a specific thing that they should be looking for in a speech therapist as they move forward?
Yeah, and I think I know who you're talking about, and I know they were getting ready to do some LSVT services. And again, it would be someone that really understands that link between the voice and speech, but then can also provide some other complementary services and change up the treatment if someone needs something in addition to LSVT, and adding that in, trialing some different techniques, and pacing particularly is one that might be helpful. And so, yeah,
Another question is, who writes the referral for a speech therapist?
great question. It can be your PCP, so it could be your regular doctor that you go to. It could be your movement disorder specialist, your neurologist. A physician's order is what's needed, and you can just say speech language pathology, evaluation and treatment can be what the order says. It doesn't have to say LSVT per se, because it might be a different technique that the person uses, or if you're going to someone who's doing LSVT, that'll be the treatment that they recommend following the evaluation. And your physician can put LSVT in the order if they want as well.
Yeah, a couple of questions about whether or not your wellness group is accepting any more participants.
Yes, I haven't started doing any, I guess you could call it marketing. I don't know. That always sounds funny to me because but marketing, letting the community know about the group. Our next group is going to be in May, and I usually start working on getting the groups pulled together in April, and so. It's almost always posted on the APDA Massachusetts website. And so it will be in May. And yes, I am still accepting people for the group. So um, be happy to have people join us. So be looking for that on the website.
Absolutely. Another question is it possible to get a speech tune-up?
A speech tune-up? Yes, that's a really common thing that needs to happen. So for my patients that do LSVT, a lot of times we will do check-ins with them to make sure that we're checking in with them about every 6 months to see how they're doing. People can come in and get a re-evaluation. It is really not uncommon for people, particularly if they stop doing their exercises at home, which, you know, it's just like anything else. You have to keep doing it and you have to keep the home program going. So if you've fallen off the wagon for some reason and you've kind of had a decline in your skills, it was not uncommon at all for me when I was in full-time clinical practice to have people come back and maybe do a 2-week stint of therapy to get them back up to where they were. So very common, to be expected, particularly with this diagnosis, and we expect it and we know just what to do with it.
Good. I have another question regarding hearing aids. An individual has a spouse who doesn't wear the hearing aids because the individual is afraid that they might lose them.
Hmm.
Is there anything that you would recommend um, to reinforce the fact that they need to wear their hearing aids? Um,
Well, that's one of the reasons that I covered the content today that I did, because I don't know that everyone is really aware of the importance of it beyond just being able to hear better every day. It's also, obviously an aspect to people's cognitive functioning as well. And again, I'm not an expert on it, and I'm not a researcher in this area. However, we know there's a link, and we're trying to piece that link out. It's a really important reason to keep them. People usually have an insurance. You can put your hearing aid on your insurance policy a lot of times. There are a number of different ways that you can maybe try to help reassure that person that it's not meant to be in the box in the drawer. It's meant to be in their ear. And that's the only way that it can help them. And it's vitally important for them to wear it. There is a period of time where people have to get used to them because, the brain adjusts to not hearing. And when the brain starts hearing again, it can't always make complete sense out of this, you know, it's not just a switch that gets turned where you just go right back to being able to hear like you always did. So there's a period of adjustment. Another reason to go to an audiologist, because they will work with you through this period of adjustment and really help to educate you and think of a lot of creative ways for you to not lose. We even have on our website at UMass, we even have something about wearing masks and hearing aids, because a lot of people are worried about losing their hearing aids because of taking masks on and off. And we have a little educational PDF up on our website about that. But there's a lot of, they're expensive. And so I understand why people are worried about losing them, but they don't help you in the box.
Good, Lisa. I think that's it for the questions. If we want to thank you so much for your presentation today. It's been incredibly informative. If you have the chance, if you could just advance to the next slide, that would be great.
Absolutely.
I want to just tell everybody a little bit about the APDA of Massachusetts. We have our Optimism Walk coming up. It's on Saturday, May 22nd. Our walks actually fund a lot of the programs that we do in the field, the presentations, the support groups. We support individual scholarships, and we have exercise programs in the field. It's an incredibly important fundraiser. This year, it's going to be held virtually, and we'd love for everybody to participate. And the funds used benefit research approved by the APDA Scientific Advisory Board and the APDA Information and Referral Network. And so the repository for everything that happens with APDA is on our website, as Lisa had mentioned. If you could move to the next slide, please. This is our social media breakdown. We're on Twitter, we're on Facebook, we're on Instagram, and we have a website. We also have a YouTube. I know that there have been a lot of questions today regarding, the presentation. The presentation has been recorded. It'll be up on our YouTube channel, hopefully within the course of the next couple of days. And so that will be available for people to, listen to again or share with important people in their lives with Parkinson's disease. We want to thank Lisa, who has been an incredible partner to the APDA. She has been incredibly informative and helped us, navigate through this challenging time. Um, After listening to this presentation, and each time I interact with Lisa, I gain even more appreciation of everything that she does. This is important information, and the APDA is certainly fortunate to have people like Lisa as part of the team. And so I want to thank you very much today, Lisa.
Well, you're most welcome. I'm so happy that I could share this with everyone.